asked to come speak at this chat with Dr. Konda. And coming into this and just glancing over Dr. Konda's, some of his writing, I kind of saw as anti-private equity. And if you listen to a lot of some of the Democratic candidates, it's almost capitalism versus socialism. And so I thought this was going to be, you know, just a point counterpoint. But I really got in it and I read Dr. Konda's research, and it was very well thought out. I'm not familiar as derm as I am with most other specialties, but when I really read it, it resonated because it was based on the research he's done and some problems that have come up. And for everybody here and for myself, I thought some of it was valuable. So I thought it'd be good to really let Dr. Konda really kind of highlight some of the areas of what he looked at in derm and some of the problems that come up and some of his thoughts on that. So.
Sure. Well, first of all, it's an honor to be here today, and I haven't had anything thrown at me yet, so that's a big positive as well. So just to go over briefly, I don't view myself as a socialist. I'm a capitalist as well, just like all you in the room. I just think in the process of capitalism, there has to be issues that we watch out for during the process because we are human, inherently human in nature. Just to give a brief overview of the dermatology market, as many of you guys already know yourselves, it's one of the hottest sectors right now that's being consolidated. In dermatology, since the first private equity firm invested in dermatology, approximately 2009, and since then, as of current day, there are over 30 private equity firms investing in dermatology. A few of these, a handful, have not made it, they become insolvent, but the rest, there's an exponential increase around 2015 onwards. Out of the more than 30, more than 25 of the firms entered the space 2015 onwards. This is a very recent phenomenon. And why is it hot? As many of you know, debt is really cheap and the stock market's overvalued. So the question becomes, a lot of dermatologists are asking is, you know, this works right now financially, but what's the elephant in the room when, you know, interest rates start climbing and the stock market crashes, investors move their capital elsewhere because they think they can get a better rate, and the hurdle rates might not be as optimal later down the future. And so that's just kind of setting the stage for what's happening in dermatology. And one of the primary concerns that dermatologists have is, you know, when a private equity firm comes in, there's a finite timeline set, more or less, for a specific return on an investment. And traditionally, when you look at the scales, you know, a PE firm comes in 3 to 7 years, buy out, invest, and then flip for a return. But we're seeing these flips happen in dermatology much quicker, 2, 3, 4 years, much shorter timelines. And so when these flips happen so quickly, get concerned as, you know, how many flips will happen. The more flips that happen, what happens to the company with time? So that's one of the things.
Well, just on that point, and maybe dermatology is different. I guess I look at healthcare and where private equity and what a lot of people here are doing is looking at healthcare into the future. And one of the things that I think you were here, and maybe, I don't know, your thoughts on that, but a lot of people, the common wisdom is fee-for-service model. And is one of the big problems, that the fee-for-service model, when you pay for procedures, what do you get? You get more procedures. And the common wisdom about going to bigger groups and being able to do data analytics is be able to take risk so that providers can now share in the healthcare pool, but also help bring down costs. So I see private equity as being very, very important because, you know, smaller physician groups and even larger ones don't have all the expertise and the capital to grow, to be able to get big enough to take risk. So one of the things I'd like to understand is dermatology different? Is it different because a lot of it's cosmetic? There aren't enough dermatologists that, you know, are they outside the rest of the healthcare? Is it more of a specialty unto its own?
Traditionally, it has been unto its own, but as times change, we become integrated in larger networks, regardless of the type of practice model. One thing unique to understand about dermatology is the revenue streamlines. And so there's two very big streamlines. One is that skin biopsy. once that skin biopsy happens, there's a trickle revenue stream that goes downstream. The skin biopsy happens, CPT code for that. Then the pathologist reads it. There's a global code for the pathology, read technical and professional components. Then if it ends up being a skin cancer, it gets referred for a procedure, which could be Mohs surgery, is a very expensive procedure, or an excision, or another type of local destruction. And so that one triggering event, the biopsy, and also dermatology is exemption to the Stark law, it can keep everything ancillaries in-house, that triggers a whole financial downstream event of quote-unquote productivity. So that's one thing to be a slippery slope, especially with the exemption to the Stark law, is that there's this incentive to do more, to keep your finances up in a well-oiled machine. The other issue we've seen is there has been an amplification in the use of physician extenders in dermatology. That is a big point here. And yes, are physician extenders used in all practice models? The short answer is yes. We have them in UF, they're in private practice. They're an integral part of the healthcare team. We've seen issues happen, though, in the private equity model where extenders are not working in the same office as a doctor. The doctor's not even available on site for the extender to talk to the doctor if they have questions. It's a spoken hub wheel model where docs in one office, there's 3-4 satellites in the same city down the street, different state even, and they're supervising these extenders remotely. And that can be a question of, is there really quality of care and value being brought to the health system? Many of you may know there are several published studies in the peer literature about physician extenders and biopsy rates, something called number needed to biopsy. That's the number needed to biopsy for someone to catch a skin cancer on average, whether it's a squamous cell, basal cell melanoma. There were 2 studies in the past that document that physician extenders or advanced practice practitioners have a higher number needed to biopsy than physicians. And even this past month in JAD, there was an article that came out that showed that physician extenders or APPs have to biopsy on average 4.69 times to catch a skin cancer compared to a physician, which only has to biopsy, a dermatology board certified physician, only has to biopsy 2.82 times. That's a 1.6 times difference in the biopsy hit rate and how they're catching skin cancers. And the elephant in the room question here is, is that a concern or is it not? Because honestly, at the end of the day, a higher number needed biopsy is more revenue, and more revenue is good, but depending on the lens that you look through it. So that's some of the concerns unique to dermatology.
Well, you brought up some very good points. I think an obvious big one is you have a pharmaceutical company that was selling, narcotics. And they clearly, for profit, they got overzealous, and look where it got them. What I can say is, being a doc, I had always had strong feelings about physician leadership and good, strong physician, always respected good medicine. That being said, I also see, I got to see healthcare nationally. And I don't think it's really just private equity. I think that it's interesting. I think that dermatology, I know, and this is just anecdotal, a lot of physicians going to dermatology because low numbers, highly lucrative, big cosmetic component to it. So part of it is dermatology selecting out physicians, first that sought out private equity, but also tend to be just looking at it more from a dollar perspective, which gets to a bigger issue too, because it's, I think, with all specialties. A couple of weeks ago, there was an article in the Wall Street Journal talking about vascular surgery. And in an office setting, Medicare pays an average of, say, $15,000 for a distal stent in the leg. And how many more physicians are starting to do it now? But there are very strict criteria for doing it. So this really gets back to, we'd all like to believe, or as a doc, I'd love to believe that all my brethren do everything for the greater good. There are a lot of good doctors out there, and I think that's really one of our charges here, that if we're going to go into business, if private equity is going to get into bed with physicians, first it's really understanding how good that physician is, their integrity, getting to know them, and as part of it, the cultural fit of wanting to do good. I think just an important point is, when I speak to private equity folks about, say, a practice I may have or somebody else, the first question that usually comes up is, what's their EBITDA? I don't think anybody's ever asked me, are they good docs? And I think everyone here in this room would much rather be associated with physicians they could be proud of and feel good about, that are doing, good work and not overutilizing. But that's a harder thing to find.
You bring up an excellent point about overutilization, and as you know, I perform research in this area, and we analyzed, Medicare data over a few years, and we found that some private equity firms were acquiring outliers in skin biopsies, and we looked at the top 25 outliers in the country, and 5 of them had been acquired by a private equity. And uniquely different private equity firms. Some of them were acquired as even platform models. And so, interestingly enough, once the paper came out, a 6th one was acquired. And so you would hope that once the list is out, that that's the do not touch list, but someone else acquired it. And also we looked at intralesional injection outliers in Medicare data set also, and we found that they were physician extenders that were going to nursing homes with one of the private equity-backed dermatology groups, and they were performing intralesional injections at skyrocketing rates up to 17 times per Medicare patient per year. On average per beneficiary. That's more than 1 time a month. So the question is, what is going on and what's being injected? So these are some examples that bring into question, I know everyone talked about here about value-based care, driving quality, which is great, but where's the due diligence if outliers are being acquired? So that's the question and the concern. So.
No, I would agree on that, but knowing, some of my brethren in the room, some of the private equity players here, that from my conversation with them, they are concerned about those issues more than they were a few years ago, because I think that as they're in the business longer, they are recognizing that good doctors make for good business. But an interesting one came up. Mr. Bloom in the room here was involved in a surgery center. He was doing a transaction in a center in Northern California, and there was one orthopedist there, who I'm sure he'll remember, who probably did 4 times the amount of knee scopes as any other physician. He'd work 2 rooms, he could do 20 knee scopes in a day. And one of the concerns, and it was a concern for me especially, because I was a partner in that surgery center, first of course was, God, look how busy he is, this is great, we can all make money. But in thinking it through, are we all gonna get into trouble? And really actually went to Stanford, got an outside reviewer to go through his cases to really make sure that who he's operating on and the cases he was doing were really warranted. And it turned out he just had a really unusual referral base of getting patients that really did have pathology. But even though I stood to gain a lot of money from this physician, I was ready to lose it rather than risk having somebody who would overutilize.
I think one of the other questions / concerns is, it's the stages of the flips. So, the first flip's honestly not that hard. Platform practice, get some add-on acquisitions that we talked earlier today, and consolidate either regionally or spread out a little bit more geographically. And you can garner that with economies of scale. That's something you guys are bringing to the table, economies of scale. Nobody can deny that. Once you get past that first flip, how do you get to that second flip and third flip? And we've seen some of these larger derm groups, not to name names, that are actually struggling a little bit at that second, and some of the third flip right now. And once you get to a certain size, you can potentially have diseconomies of scale. And then the question is, how much can you reap out of that financially with each successive flip? And at what point do the doctors get affected or quality care get affected? Because no matter how quote unquote good a current firm may be, who's the next buyer and what are their goals and objectives? And the question is, it could be another private equity firm, it could be a healthcare conglomerate, and of even bigger concern could be an insurance company. That's vertical integration, as we've alluded to here today. And so when an insurance company acquires doctors, they could basically dictate what doctors are able to treat their patients with, even if it's good ethical care. And 2, they could actually restrict insurance participation for physicians that are outside of their acquired physicians. Just make patients see only their acquired physicians, regardless of the patient's interests or wants or desires. And so I think questions to ask, we're looking 5, 10 years, you know, right now, it may be okay to get to that first flip. It's that second flip and that third flip. And I know once you get that second flip, you have to really drive home that value creation message where you have this big model and you flip it and you can really drive some more value to the system. But what happens, not just this first flip, second flip, third flip onwards. So.
No, it's a good question. I don't really have the answer to that. And maybe somebody during the question and answer can
Sure.
address that.
And then other concerns, you know, boom and bust every 10 years, you know, and we're in that boom phase. So the question is, you know, how long will the boom last? That's a big question as well.
Well, I guess from my perspective in really seeing it, and I think if somebody invests, you know, private equity group invests in a right physician group, and they're, you know, obviously they have the money to get the deal done, I don't see healthcare dollars drying up very quickly. And if you're looking at a business model for that's, you know, building into growth, somebody, a couple of speakers back spoke about income repair. When you're looking at income repair for the physician, which means you're driving, whether it's more ancillaries or you're bringing other practices on, and you're bringing real growth, you're now taking risks, you've brought in a bigger patient pool. I can see these, you know, groups as being self-sustaining. I guess I'm less worried about that risk, you know, the money drying up, because I think there'll always be money for that. And if a group's profitable, whether it's debt financing or something else, as long as it's fitting into a good business model.
You know, on that note, you know, we've seen a handful of stumbles in the dermatology market. You know, one of the first groups that was PE-backed was U.S. Dermatology Medical Management in 2009. They acquired a handful of practices, then stumbled, and then became insolvent. And then Derm One Dermatology, I'm sure many of you know in the room, their investors pulled out the funding. You don't know the minor details behind the scenes, but their investors pulled out, Westwind investors. And, you know, what happened to those practices? Some of the doctors bought it back on the cheap. They actually became winners. Some of them were actually sold or acquired by other private equity-backed groups in their regional markets. And even the patient records were sold to one of the private equity-backed groups in Texas, some of the Texas-based records. And interestingly, you know, one of the concerns also even in dermatology is, some of you may know, there is an alliance called the Dermatology Practice Support Alliance of head executives from the private equity world and some of the CEOs that are in this consortium with potentially aligned interests. And to this day, we haven't heard or understand why this exists. What are the purposes of it? Is it a lobbying organization, or is it an organization, you know, Betsy Worley, the forefront deputy president, she says you know, it's an informal group that met over breakfast, but that's all that we've heard so far. So I think you can all alleviate some of these concerns if there's more forward-facing information for dermatology, and we haven't had that, so, yeah.
Well, just following up on looking at the numbers of dermatologists and just anecdotally looking at getting an office visit with dermatologists in my area, I see problems with access and about the number of dermatologists who are still doing day-to-day dermatology, where a lot of them just want to do cosmetic. Now, how do you see that from, you know, your teaching institution, you know, your residents getting out? Does dermatology, will it continue to have an access problem?
I think the access argument is always out there. Is every resident coming out wanting just cosmetics? That's not been my experience. I do think there's a select portion of derms that say, you know what, I want to go out, only practice cosmetics. And honestly, those are the derms that, you know, they're going to be cash-based. They don't have to fight with insurance. They don't need any leverage. And so they're usually in their solo silos or boutique practices doing their own thing. But overall, you know, dermatologists, what we've seen, they want to practice the whole spectrum of dermatology. Some do subspecialize into Mohs surgery, derm path, other subsectors. But overall, we've seen the whole breadth of people coming and practicing. The access question, I think that argument is substantiated. It has a strong footing in actually underserved markets, whether, you know, it's the middle of nowhere, Midwest, or Arizona, or somewhere that there's just not a great density of dermatologists. But when you see big groups going out and consolidating, putting out extenders in New York City, middle of New Jersey, Orlando, that's not an access issue. There's no argument there for the access issue in those areas. So I think it depends on what market you're in. So.
Well, actually, an interesting point you brought up just about areas of the country that, there is a need. Is this part of the business model if they haven't really embarked on it for some of the, whether it's PE-backed dermatology groups or just dermatology groups, to get into telemedicine more?
That's something I haven't seen much as of yet. Are you aware of?
I've seen a little bit of it. I've seen, like Kaiser out in California has started to do that in more remote locations. I mean, they have an interesting model in their hospitals in Silicon Valley. They have a roving dermatologist.
Yes, I've heard of that.
So that somebody goes into their primary care doctor and they have a lesion, rather than reappointing them for a dermatologist, they'll actually have someone come in while they're sitting there, get them on the phone, and they'll come in and see them on that visit, which is actually an interesting model also.
It is. It definitely is. I'd like to share with you, I was reached out probably like a month or two ago from an unnamed private equity firm, not current investors in the dermatology space. Sent me an email, we had a good dialogue, and I just wanted to share with you some of their analysis, some of their research. And this individual said, and I'm reading quote unquote, the roll-up wave fueled by cheap debt in the sense that it's quote unquote easy financial engineering has spread to ophthalmology, GI, pain med, and now orthopedics. All of it is underwritten by more procedures, more biopsies, and always with the insourcing of ancillaries. The particular twist in derm is the acquisition of the local DermPath lab by the private equity group. These labs often go out of network after the private equity group buys them, and the patient then gets surprised by a massive bill for a biopsy for which they had no choice in lab. By our analysis, nearly 50% of U.S. private equity healthcare activity last year was in a physician practice consolidation. That is a shocking, disconcerting, and a quality issue and a patient financial issue waiting to happen. What I've been hearing lately is that the derm roll-ups are all way below profit expectations, and the big ones are looking to merge with each other. This is entirely predictable and all won't end well. And it goes on and on. So I think the question is what happens when the finances get tight? Will we have big mergers in derm, big conglomerates? Will some disappear overnight? And so these are, do I have the answers to the questions? No. Do you guys have the answers? Maybe not as well. Time will tell. But these are concerns that even some of your fellow private equity firms have as well. So.
No, it's a great point. I guess I'm still heartened by the fact, and maybe I'm the eternal optimist, but even folks I was talking to this morning, and even hearing some of the people talking today about their thoughtfulness of picking the right groups, looking at real growth plans, trying to get cultures to fit, are really looking at this not in just a mercenary way. Yeah, it's a way to make money, no question about it. But I really think that after a number of years and hearing some of the things that didn't go well, seeing some of the litigation with physicians being unhappy with some of the groups that have gone on, I think people getting into it now and people putting money into it are being more realistic, and hopefully it will help benefit healthcare as a whole as we get to bigger groups and different payment models.
One other thing, I enjoyed one of their speakers, great lineup today. I enjoyed one of the speakers that mentioned, private equity firms be careful sending emails suggesting to do certain things to get patients through the door. And we've heard that happening in dermatology, whether it's, freeze every actinic keratosis, let's make a policy for that, or it's time to bring in all the melanoma patients in for a skin check. We should refer everybody that meets appropriate use criteria for Mohs surgery to get Mohs surgery. And appropriate use criteria is basically a schematic devised by our societies to only use Mohs surgery or offer it in certain scenarios. And it's basically gives a rating scale of 1 to 9, and 7 to 9 is where it's appropriate. And that's not mean you have to mandate the Mohs surgery, it just means that the patient can have that as an option if they desire that for care. And we've heard reports of there being pressure to, if it meets that appropriate use, send it for Mohs. And that's where derms are also getting concerned, is this unspoken, slightly indirect pressure, suggestions for patient care, not just some of the groups. And there's that line between the PMC and the MSO. And as been alluded to many times in the room, the MSO essentially is a creation or vehicle to circumvent corporate practice and medicine laws that were designed to keep physicians independent from investors. And once that is circumvented, you have the MSO and PMC in place, and you have your aligned physicians, your friendly physicians, or your anchor physicians, however you want to call them. That line should stay divided, and we haven't seen that completely stay divided in dermatology. So.
Well, I do think that the clinical component of care for physicians should be carved out clearly for everybody's benefit, the liability for the private equity firms or the corporate firms, and also for the doctors. But I think there's an obligation for all of us to encourage the physicians to practice good medicine first, And again, I think it is compatible with still being profitable. But again, comparing to the Mohs criteria surgery, somebody comes in with knee pain, and you say, oh, well, I took my Advil, it didn't help. Oh, let's get you in for a knee scope. But it's really, is that patient going in for the knee scope too soon? With physical therapy help? Can you avoid it? And it's really giving the doctors kind of, I guess, the encouragement to practice good medicine. Eventually, the patient will either have the surgery, they'll need something else, or they'll need some different procedure later. But it's the old, don't do any harm, but at the same time, with, $3.2 or $3.5 trillion in healthcare, and 18% of the gross domestic product of the United States is healthcare costs, there's still a lot of money to be made with making the system much more affordable for patients and getting rid of inefficiencies in the system. I think we're down to probably question time.
Sure.
Any questions for either of us?
Hi. Is there a mic or no? Okay. I heard your comment about...
If you could wait till the mic. Thank you. I heard your comment about clinical variation and potential overutilization and lack of clinical oversight and compliance. I'm wondering, and I heard your comments about those providers being acquired by private equity-backed dermatology companies. Wondering if you're continuing your study and research post-acquisition to see if the utilization changed due to, increased compliance, oversight, and other quality programs.
No comment.
Okay.
Dr. Pruzansky, as a fellow physician, I have a skeptical eye that you are thinking that companies that are paying, 10 times the EBITDA are mostly interested in high quality, good doctors. It doesn't resonate with the practicing physicians. It's about money. We heard that from somebody earlier speaker. You got to look at, it's two different things here. One side is about money. So that being said, my questions for Dr. Konda, we got a big concern. I'm actually in emergency medicine, which is the mature market, and we're number 2 or number 1 in burnout, depending on how critical care is doing that year. And we're hearing a lot of it is doctors feel that they're just working for the man. They're cogs in the wheel. They're being exploited. 2 o'clock in the morning, they're taking care of an opioid overdose, and they know that money is going to somebody else who's not doing that shift at 2. Now, I heard a quote on a podcast saying that this whole model is predicated on the next generation of physicians working harder for less. And that's going to really create future problems. I don't know if it's happened in derm yet. It certainly happened in emergency medicine. That's going to affect the quality of care besides the other things you're putting out.
I agree with a lot of what you're saying. You bring up a great concern. What's going to happen to the next generation of dermatologists or physicians or ER doctors? And right now, when these deals are structured and happening, you have these 2, 3, 4, whatever, small, medium-sized group practices that decide, you know what, I'm tired of administrative duties, let's sell it, give a fair market value fee to the MSO, and just move on with their lives and practice clinical medicine. early and mid-career physicians are being shafted in this process. Many have joined small and medium-sized groups, and they were joined with the promise of a partnership track within 2, 3, X amount of years. And what happens, these deals are structured overnight. These early mid-career derms, they come in and work the next day, and whoever owns a practice, whatever it's like multiple of them or just one solo doc, they say, hey, I'm selling to private equity. We structured a deal, buyout's happening. Sorry, guys, your partnership track's out the door, and make it or leave it. And then, guys come in, you restructure the deals, give them a new contract, maybe like a $30,000, $40,000 bonus to entice them to stay on for a little bit. But that's when you get the rogue physicians that come out. They say, you know what, this model wasn't for me because I was shafted and I didn't get what I was promised from a partnership track. And they're the future dermatology or any physicians, and they're being sidelined. And then when they're sidelined, as another speaker alluded to, there are ways to keep them in check, whether it's through non-disparagement agreements, non-compete clauses, so they have to go farther down the block to practice. And, these are all legal tactics, obviously, that's why they're used, but it's not a good reputation or a public image to have when doctors are pressured like this. And, I get docs that reach out to me and tell me what's happening, and they tell me that, last week we were bought out and I had no idea and just came to work the next day, and that was it. And so it's something that doesn't give a good PR image, as I'm sure the next speaker may allude to.
Well, just back to your point, I think the deals that I'm getting involved in, we're clearly trying to keep, because I represent the physician groups, trying to keep clinical control in the physician hands. And I know there is pressure from somebody coming with, spent a lot of money on a practice, there is pressure to do it. But I think that as much as possible, I think my role in representing physician groups is to carve out clinical control. I think that's imperative. And, it's what I'll continue to do because I think, physicians do need to be controlled of the medicine. And getting back to, I guess, the statement that you think I'm giving private equity too much credit for having a heart.
Yes.
I guess part of my agenda was to make the point that if they do, not to have a complete big heart, but that, that by looking at some of these softer issues, it is good business. It can help their relationship with this group they just spent a lot of money for. And again, hopefully have a group they'll be proud of. So I would just hope that message resonates. And again, before asking their EBITDA, ask if they're good docs.
We've seen some of these questionnaires are publicly available, even on some of the PE-backed group websites. And these questionnaires that doctors have to fill out when they're being courted for a deal, these are the questions. How many biopsies do you do a year? Do you read your own pathology? Do you do your own Mohs surgery? How many extenders do you have? And that's the crux of the questions there. If there's really quality and value-driven healthcare here at the forefront of this equation, we should be seeing questions like, what's your number needed to biopsy to catch a skin cancer? What is your hit rate on benign to malignant lesions? Are you biopsying all benign nonsense all day, like keratoses that don't mean anything? Or are you actually biopsying and you have a good hit rate and you're catching all the skin cancers, so you're driving down healthcare costs and you really are here for value-based, quality-driven healthcare? So as long as you're seeing questions like that, it's kind of divergent of, is this quality or is this purely numbers?
Okay, knowing what you know, you've clearly done the research. If somebody came and gave you a bunch of money and said, we want you to act as the private equity group, could you buy a dermatology practice, and do you think you could grow it and make it profitable in an ethical manner?
Could I or do I want to?
You can take it both ways.
Well, it's a million-dollar question, I guess, pun intended. Could anybody, I'm not going to say myself, could anybody buy a practice and grow it to make it more profitable? The short answer to the question is that yes, that you can. Whether it's being financed by debt or private equity, whatever that financial model is. The question is for how long? For how long can you have that profitable? And after how many flips can you keep it profitable with still good ethical patient care? No one's arguing that first flip. You just buy up and consolidate. It's that second flip, that third flip and onwards, where Can you make a profit? Well, that's where I don't have a good answer for anymore.
But you can run a good ethical group and make money without worrying about the flips.
That's tough. It's a tough thing to do. I haven't done it, and make money for an outside investor, you mean? Or
Yeah.
that's tough because the investor always wants their hurdle rate. They always want to get back with for their investors on the ground. So if there's that constant pipeline of revenue, a revenue stream that's being diverted for either a limited or a long-term plan, it's hard to say how long that's sustainable.
Thank you.
Thank you.